Hello, everyone, and welcome to today's Triple Tree Thought Leadership session. Before we get started, I'd like to go over a few items to help you get the most out of today's session. You've joined the presentation listening using your computer's speaker system by default. If you'd prefer to join over the telephone, just select telephone in the audio pane, and the dial-in information will be displayed. You'll have the opportunity to submit text questions to today's panelists by typing your questions into the question pane of the control panel. You may send your questions in at any time during the presentation, and we'll address questions throughout today's discussion. At this point, I would now like to introduce Michael Carroll.
Good morning and welcome to Market Insights Live. My name is Michael Carroll and I'm the Chief Marketing Officer at Triple Tree. Today's session is focused on the enhancements that health systems are making as they improve their operations across reimbursement, cost, quality, and administrative areas. A reminder that the views and opinions expressed in today's discussion are those of our participants and do not necessarily reflect those of Triple Tree or its affiliates. To begin today, I'd like to introduce today's panelists, representing a great spectrum of organizations across this important spectrum. So first, I'd like to introduce Tabitha Lieberman, who is the Senior Vice President of Clinical and Revenue Cycle Applications at Providence St. Joseph Health System. Providence is the nation's third largest health system, providing services in 7 states in the West. In her role, she is accountable for application delivery and implementation across Providence, including both owned and non-owned affiliations and joint ventures. Tabitha, welcome. Next, I'd like to introduce Ivana Nami-Rod, Chief Operating Officer at IMO. Intelligent Medical Objects is a healthcare data enablement company that ensures clinical data integrity and quality, which makes patient information fit for purpose across the healthcare ecosystem. In her role, Ivana leads the company's software engineering, content development and delivery, project management, and enterprise IT departments. Ivana, welcome. Next, I'd like to introduce Hoda Syed Friel, Executive Vice President at Meditech. Meditech develops EHRs to simplify and enhance clinicians' interactions with patients. In her role, Hoda charts Meditech's strategic direction, overseeing the evolution of Meditech's EHR capabilities to create innovative products and provide value and optimize the customer experience. Hoda, thanks for joining us today. And next, I'd like to introduce Dr. Yading Yu, Chief Medical Officer at Olive. Olive is a company that uses AI to address some of healthcare's most burdensome issues, helping health systems increase revenue, reduce costs, and increase capacity. Yading is an international keynote speaker, a Harvard physician, published researcher, and a serial entrepreneur across healthcare technology. And she's a return Market Insights Live participant. Yading, welcome again. And last, I'd like to introduce my colleague, Seth Neller, Managing Director at Triple Tree. In his role, Seth specializes in healthcare technology with a focus on tech-enabled platforms serving the provider and payer end markets. Seth, I'll turn things over to you now to share a few thoughts and perspectives as we begin today's discussion. Seth, take it away.
Great. Thanks, Michael, and a special thanks to our fantastic group of panelists for joining today's discussion. To kick things off, I'm going to spend a few brief minutes up front here to highlight the themes and key trends we're seeing relative to our focus today on provider operations. On this slide, you can see across the top in the illustration that providers have a range of operational priorities and increasingly complex challenges to manage. At the core of it all, there's an abundance of data and an overarching push to make this data more usable and actionable across all facets of the provider's operations. As a result, advanced technology adoption has been on the rise as health systems increasingly look to automate manual tasks, create actionability within key workflows, and leverage data-driven decision-making capabilities. Beyond the provider market, innovative capabilities and data create an opportunity for a wide range of non-provider constituencies, including payers, employers, and life science organizations that all tap into this quote-unquote source of truth to address pervasive industry-wide initiatives. Lori, can you go to the next slide, please? And I think it's apparent to all of us that we've been through a lot this past year with the COVID pandemic, and the pandemic itself has put enormous stress on the existing technology infrastructure of providers. Health systems were forced to rethink how care was to be delivered and manage their operations much differently than they have in the past. While all the while, patient volumes plummeted and supply chain issues like PPE shortages and things of the like flared up. Virtual health companies, as we can see on the far left, certainly experienced a strong first wave of heightened demand. However, as we look ahead, we see a new wave of technology and automation adoption taking hold. The slow-moving bureaucracy of the hospital environment in particular has given way and been replaced by more rapid decision-making around new technologies and tools that can provide the next generation of functionality. Next slide. In the panel discussion that follows, we're going to be exploring a number of healthcare megatrends, quote unquote, that are reshaping the provider market. Innovation, heightened demand for clinical data, and adoption of new technologies like AI and RPA, et cetera, are becoming increasingly prevalent. We expect these themes and trends to persist well into the future as providers position themselves for the opportunities and challenges that lie ahead. With that, we'll turn our attention over to the panelists, the more important part of this segment, and begin addressing some of the key topics that we explored here on the front end. So as I kick off the first topic around the COVID pandemic and what that's meant for the provider landscape, it's certainly been a change as it relates to technology adoption and the acceleration of technology adoption in particular. Providers are seeking to create efficiencies and cost savings in all areas to combat the intensifying operational and financial pressures that they've been facing. Tabitha, perhaps we'll start with you with this first question. How has COVID pushed the limits of providers' technology infrastructure, and how has your organization, Providence St. Joseph's, and other health systems adapted to this new environment that we find ourselves in?
Thank you, Seth. It's one of those large bureaucratic hospital systems. Happy to share a little of our story, and I really appreciate being invited to this conversation. A couple of things I'll set context for up front before I kind of delve into our response and some of the ongoing. So first off, I think most people heard about us early on in the news. We had the first official COVID patient in the US. And while that was scary in a lot of ways, it did give us a little bit of a head start in helping our entire health system prepare as we were seeing things unfold in first Everett, Washington, and then Seattle, Washington. We were able to take those tools and processes in clinical as well as operational learnings and spread that across our organization. The other thing to know about our organization is we have been on a massive journey to modernize, simplify, rationalize, all the things that healthcare organizations are facing, but large ones in particular sometimes have challenges with the speed up. So if we hadn't been on that journey, I think life would have been a lot harder for us. We were able to take advantage of some of the things we had started and really provide support across the organization. Later, I think we're going to talk a little about telehealth. That is the obvious one, and that is not just video visits, but how do we take care of patients at home? And we were able to stand up in a matter of weeks, actually days, remote monitoring for people who could stay home and report how they were doing, and so we could take appropriate intervention. We brought up over 7,000 providers on video visits in less than 10 days. But it's much more than that. We did great stuff on the patient care, but we were able to put in tools for workforce management to allow us to share staff across our sites and ministries, which was huge. If you can imagine in a healthcare system what it was like to be able to have staff in the right place, that was a very big part of being able to manage the pandemic. Remote workforce. We went from tens of thousands of people in our administrative areas overnight being able to work at home and not affect operations. That's from our revenue cycle, our HR, our IS, obviously. That took tons of thought into the types of tools that we needed to support them so we could continue. Communication with our patients. We talk about care a lot. There is a lot around the care that those tools were pivotal to, but people wanted information. How do I know what to do? How do I make sure I'm doing the right thing for my family? Should I go in? Should I not go in? So taking our digital tools and putting a consumer-facing front to it and allowing our patients some comfort of knowing their healthcare system had a way to interact and get good information versus, no offense, Dr. Google. So there we saw tool usage from every part of our organization. Supply chain was mentioned earlier. PPE management was one of the top early issues that we had to face. And how did we know that we had the PPE in the right place in an organization our size and scale? In the early days, everyone from our CEO to somebody in supply chain was driving PPE to the right place if needed, and that human factor was huge. As we continued through the pandemic, we really were able to start moving from pure reaction. How do we make sure we're taking care of patients, getting staff in the right place, getting PPE in the right place, sending our people home to be safe? We moved from that phase to predictive analytics. What is next? How do we see what's going to happen in our communities? What do we think our census will be? What do we think we're going to need for supply? And created whole new tools we've never had in our environment before. Some of those were temporary, and some of those are long-term tools that we will see as a core part of our organization. So I think technology was key to being able to help our organization through the pandemic, through vaccine management, and continuing on. And of those tools, we will see a large number grow and continue to help the organization, not just in a pandemic mode, but in an ongoing healthcare automation. So with that, I'll turn it over.
Yeah, well, thank you, Tabitha. That's a great perspective from the front lines. And Hoda, I know Meditech as an EMR and EHR system is ingrained within much of what the hospitals have dealt with. How has your organization supported and transitioned its hospital customers throughout the COVID pandemic? And what were the top of mind issues that the providers were challenged with addressing?
There's a few things. So to echo some of the thoughts that Tabitha laid out, we have to support for our customers, our hospitals, our physician practices, all the initiatives that they were trying to roll out and do it quickly along with them. So one of the things that we did is pay attention to telehealth and how our customers are going to use that to reach out to patients. So we offered telehealth to our customer base for free for 6 months to get them up and running and using it. We didn't want money to be a factor in the adoption of this. Most of our customers already had it in their products and just didn't turn it on, and they didn't really have a burning platform to turn it on. COVID changed that entire event, changed the entire landscape of doing that. So we helped them get that up and running. The other thing that we were being asked to do was to help them sort of categorize their patients. How severe are these patients? Which one should I be paying attention to? So we offered surveillance and created things like SOFA score, so they can actually use the data in the EHR to predict those septic patients and which ones are going to have organ failure, which ones needed ventilators more than others. So we found that they needed help with that. We used IMO in the background to help sort of normalize that data so we could sort of present it in an equal way. We also helped our customers do all the reporting, the PPE reporting to CDC, HHS, and every time they changed where they wanted the data, we had to shift where the interfaces went to ship out that data. We also had to provide coding for claims so they could actually get claims data out, and the addition of new COVID statuses and treatment plans and treatment, we had to provide the codes for those so they can get the claims out. And then we also had to make sure all their interoperability was working. So any of the patients that weren't theirs, we need to make sure that the CCDs were coming in to get that. And then As Tabitha mentioned, also communication with patients was a key thing. So our patient portal was in use, making sure that patient had access to information, how to post informational information for those patients. And then lastly, for a good chunk of our customers, they were also getting remote patient data in and trying to figure out how to get that into the workflow is what we worked on them with. So a lot of the things that our customers were doing, physicians and providers were doing, we had to support all of those initiatives and provide them with the data, with the tools, and do it quickly.
That's great. And Ivana, Hoda mentioned IMO. It'd be great to hear from you as well in terms of your organization's response.
Yeah, so Hoda called out how important IMO was in the normalization of Meditext data. So IMO is foundational in healthcare. So we are in 85% of the provider market. We're also in 14 countries outside of the US. And we have a huge responsibility at the point of care to ensure that providers can capture accurate data, accurate, specific, and granular data at the point of care. And so our team, late November, December 2019 was watching the progression of this virus very closely. And they were doing lots of outreach to various epidemiologists, specialists, both within the US and abroad, and also working very closely with various administrative and standardized code set bodies, since we work very closely with them to take our terminology and map to those code sets for things like billing and reporting. And we made a call really early January, since we knew that the administrative code sets weren't going to be ready for a few months, to do an off-cycle release and get a handful of COVID-19 related terms out early, anticipating that something was going to happen. And it was a good thing that we did, because within a week or two of that, we started seeing the numbers upticking. And ever since then, for the next 18 to 20 months, we've been doing off-cycle releases every few weeks, at least once a month, to really capture all of the different permutations of this virus, the treatments, the tests. And today we have over 1,300 unique descriptions of COVID-19 related diagnoses, labs, procedures, from comorbidity, support for long haulers, secondary manifestations due to COVID. And really this is necessary to have the ability to capture this for downstream processes to work effectively and efficiently.
That's great. And Yiding, I'll shift gears just a little bit, but on this general theme of technology adoption and the lowering of the bureaucracy and decision-making on the hospital side of things, it'd be interesting to hear your point of view in terms of what Olive has seen from providers in terms of their interest in artificial intelligence, robotic process automation, and even how that perception has changed within the last year.
Thanks so much, Seth, and thanks so much for having me. I just want to first just react to everything that my fellow panelists like Tabitha, Hoda, and Ivana have mentioned, just amount of innovation and technology uptake just to meet the changing times. I was a provider during, and I still am, and so to watch even my own health system undergo all those rapid changes both speaks to, when there's, we rise to the need. We think about healthcare innovation as sometimes being quite slow, but when we absolutely need to raise the bar, we did. And we're seeing that are reflected in your question too, in the adoption of AI and automation. Certainly during 2020, everybody had to take stock of what am I going to invest in? I'm drowning, I'm not able to get my patients, and I don't know what my financial livelihood is going to be. And so there was certainly a pause, but then there was a huge need to help ramp up testing and help facilitate and automate parts of the patient intake process or operational processes. So some of the things that we did last year was, automating coverage verification, eligibility checks for mass testing sites. Normally when you sign up with a new doctor, what do they say? Please call my office for registration. We'll take your insurance, we'll register you. That's like, I wait 10 minutes on hold, and then I spend, another 10 minutes talking to a representative to just give them my information, only to schedule my first doctor's appointment. We clearly just couldn't follow that process anymore for COVID testing if you're going to see thousands of patients every day. And so we helped health systems automate all of those using our existing technologies and revenue cycle. But then I think kind of we've really seen across this is that we've seen a lot of maturity in the entire industry. So probably even a year or two, AI, robotic process automation, all felt very nascent. You know, it was kind of cool, not many organizations doing, or they're doing it in small pockets. And now what we're seeing a lot is enterprise deployments of these as a true investment. Part of that, I think, is pushed by the financial pressures that healthcare organizations are seeing. They know that you can't, post 2020, you can't say, I'm just going to go back to normal. I'm just going to go back to 2019. That's really not what anybody's thinking. They're thinking, all right, I have a remote workforce now. I've seen that things can work dramatically different. What can I do to dramatically adapt it? And so you see organizations in that space. Some organizations are thinking, well, for simple automations, maybe I can build it myself. So I'll go and buy a software, I'll hire engineers, I'll think about some things where I'm going to make an investment. We've certainly seen some organizations do that and invest in their own builds. But I think at the same time, organizations have done that, have also realized that it's not so easy to build it yourself. Things change. If you're working, especially across different landscapes, anytime a website changes, anytime your software and EMR changes, you're going to have to maintain that build. And so I also think that we're seeing a lot of maturation of experience. So just like how 10 years ago you had provider organizations building their own patient portals, I think most organizations are realizing that maintaining and building your own patient portal is just not going to be as great as what Meditech or Epic or others can do for you. Like, go out and find a company that just does this and always keeps you at the leading edge. And so that's really where, you know, organizations like Olive have really found a real calling, where we're partnering with organizations. We work with them very closely to understand their needs. But every time we're building automation, what we build scales across the entire network. And I think that kind of partnership of understanding what makes sense to deploy it yourself and what makes sense to partner with an organization that is on the cutting edge, I think that in the market has become much more mature. A lot of our buyers are getting very sophisticated in that area.
Yeah, no, we would agree. And on that general theme of the maturation of the industry and what's driving kind of the new normal here, there's also this concept of demand for clinical data and interoperability, greater information flow amongst all constituents, and very, very high demand from what TripleTree's at least seen in the marketplace. So maybe turning to you, Ivana, what specific initiatives have you seen providers prioritize as it relates to unlocking the full potential of clinical data and using it to enhance their operations in various ways?
Yeah, so, you know, me and my colleagues at IMO, we're seeing that a lot of these providers are prioritizing data quality and data standardization initiatives. And, you know, we talk a lot about data quality in healthcare. We hear it in the context of things like value-based care, you know, obviously in the context of the topic of this panel, you know, operational efficiencies, things like being able to provide more accurate insights into risk profiles, better cohort identification. Seth, you called out the supply chain, you know, making better purchase decisions because of quality of data. You know, feeding AI and ML. I was just watching a Google Health video about how much time the data scientists spend. It's about 80% of their time just cleaning the data, because the output of those models are that much better if they spend their time on the data cleaning versus tuning the models. And so we're seeing this being a huge initiative for many of our customers and the industry in general, because without it, there's a lot of operational inefficiency being spent doing it manually or having to invest in processes to do it, if they can even get to that clean state. So yeah, at IMO, we're leveraging the specificity and granularity of our data to help customers do that. And to help them become more efficient. And actually, I have a personal example of this that, you know, didn't think that it would happen to me, but my sister-in-law was recently diagnosed with breast cancer, and specifically breast cancer stage 1, and it was estrogen receptor positive. And it was properly captured in her medical record. But as she was getting referred to other specialists, because on top of this diagnosis, she was also pregnant, that estrogen receptor positive indicator dropped off. And so what happened was, when she got to that specialist, there was all of this back and forth between specialists, the oncologist, the OB, her primary care doc, to try to get to the root of what even caused this data discrepancy. And on top of it, she was prescribed medication that had estrogen impact. And so not only is this causing inefficiencies and inaccuracies in healthcare, this is a very serious patient safety issue. And I'm really happy to see that providers are prioritizing this as an initiative.
Mm-hmm. That's interesting. And Hoda, I know, as these technology initiatives have accelerated dramatically over the past year and even before that, how have you seen providers leverage core EMR data that is captured within Meditech systems, but also incorporating a wide range of other complementary data sets? How are providers beginning to think about data just more broadly?
I think what we're seeing happen is the EHR is going to be sort of a pool and an aggregator of data from a variety of different sources. So diagnostic data is just not enough anymore. So they're looking for social determinants of health. So whether they're getting it from a portal, getting it from an app, they're more receptive now to consumers actually contributing to their records. So that is a big move forward. I think for this industry is to get the consumers involved in it. And we're seeing that the consumers do actually want to interact and contribute data to their record. So things like Ivana mentioned don't happen. So someone can just basically say, I have this, I can augment my record with this information. And providers are being a lot more receptive to that information. The other thing that I see happening as all this data is being aggregated into the EMR is genomic data. So patients are getting, via 23andMe, or if they're just getting genomic testing for other reasons, for cancer reasons, oncology reasons, they want that genomic data in their EHR so they get a complete picture of what's happening. So the consumers want it, the physician, the providers want it, so all that data is being there. Meditech actually introduced a genomic application integrated with the EHR. So we wanted to make sure that if we're going to make an impact on healthcare and impact on decision making, that information has to be both from the patient, both from genomic areas, both from interoperability, moved into the EHR and moved into the workflow of the clinician so they could make the proper decisions. So as we're seeing all of this data being generated from all these sources, the new mission of the EMRs are to bring it all together, make it relevant, and provide it and put it into the workflow. So that is really sort of the top of mind and basically what we're all working on, so that we can actually not only provide the best patient experience, but the best provider experience in helping them find a treatment, fine-tune a treatment, and do the right thing.
Great. Michael, is there a question?
There is, and it sort of links to this discussion and goes back to a comment, Tabitha, you made earlier. There are a lot of different capabilities out there for remote patient data. So what is it going to take to actually kind of adopt those capabilities and let that data flow through the system so it goes into Providence, into the EHR, and then out to IMO? Like, what's the catalyst and sort of how is that all going to work in this new next normal?
Well, I'll start with the caveat of we don't really know yet. We know that we do need to do this. We know the nomenclature, as mentioned earlier, and the standardization is critical. We know that we will be experimenting with a lot of new technologies. Some we had dabbled in before, like chronic care management and uploading your glucoses. Those are simple things people have done before. Two, really, can we do care at home instead of the hospital where appropriate? Which will be, people have looked at that, but in a much more serious way today. So we will try a number of things. There will probably be some aggregators out there that help, that bring things together. But what we want to start with is, where does it change care? And so with all those technologies out there, our real focus is how do we provide better care in the right place and use that as our guidance to pick the tools and see what works and doesn't, and continue to work with our vendors to come up with ways that best serve those patient cases. back to, we don't fully know yet.
Well, that's a great segue, Tabitha, to a comment that Yiding made a little bit earlier in terms of working with providers, and Tabitha use the word experimenting. I mean, I think there is a kind of a focus on other new use cases and applications of new technologies, and so it'd be interesting to hear from Yiding in terms of how you guys partner with health system clients and really sort out ways in which you can help them solve some of these problems, some of which they don't even know they have yet.
Absolutely. I think that that's a really fun part of innovation, is that you're always looking for the next new thing. It's not always just solving current state for better, but what else can we do? What else can we imagine? And we truly think of it as a partnership. One of the very unique ways that we go to market is that our contracts are at risk. And so many vendors don't do that. They say, I'll charge you this fee or implementation fee. We don't do any of those. We don't charge an implementation fee. We don't have a service fee. We deliver results. And if we don't meet those results, then it's on us. And so you can see that we're really aligned with our partners by doing so. And we also structure our partnerships so there's governance, so that, whether it's a physician leader, revenue cycle, and technology leaders, they all come together to say, here are my strategic priorities. This is where I'm looking to meet my business objectives, and how can you be a partner to do so? And so because of that, we essentially, work across the entire health system. A lot of it is clearly in the revenue cycle, where a lot of operational efficiency lies. So from front end revenue cycle, like coverage discovery, prior auth, to back end, like claim statusing, automated first pass appeals. But we also do work in supply chain, empanelment, 340Bs, call centers. So it's truly across the operational footprint. But I think what's really interesting is that, initially people thought of automation, and now AI. When I mean AI, I'm talking about, machine learning, natural language processing. How can we take, parts that are normally done by, trained humans, and allowing the computer to help make those insights? Initially, there's a lot of thought on cost cutting, on just how can I save dollars. But now what we're really seeing, and where we think the market needs to go, is how can we meet your business objectives, which is increasing your patient throughput, like Tabitha says, giving patients better access to care, and focusing on things like that bring revenue into your organization, not just to figure out ways to kind of cut the bottom line, because that really is not how to optimize the system. If you run incredibly efficient system, you'll get more patients in, you'll be able to service them with your existing resources, and that's what we want to be able to do. So a lot of our successes has been actually able to help our customers raise their revenue and actually increase their top line margins. And I mean, when margins are already as thin as they are, that's a win-win strategy. And I'll just end by saying, we think about this, especially as how can we make sure that everything we do also is surrounded by data. So you don't just build a widget and release it into the wild and say, now I'm done. Everything that we do, we believe, has to be connected so that leadership and the entire organization has insight into what's working, what's not working, and be able to take actionable steps to impact their health outcomes or impact their business outcomes. And if we're not delivering that, then it's as if you installed a printer outside of the network. I mean, the printer will still work, but if it's not connected to the network, only certain people can use it. It'll never benefit from upgrades. Like, we need to create the internet of healthcare. We need to make sure that everything is connected, that we can't build in silos. And so that's really that's part of our organizational philosophy, is creating that internet of healthcare, so that anytime we're partnering or building, we make sure that our partners have the whole benefit from it, but also that anytime that we're learning an insight from, our market in Florida, we can benefit our market in Washington as well. That it's not siloed insights, but that everybody benefits. Because frankly, your payers, your patients, they're all moving across the country, and we need to follow them. We need to be able to kind of raise all boats. And so that's a core part of our philosophy. And I think our market is going there.
That's great. And Ivana, your organization kind of plays a similar role in that you have so many providers out there that use IMO in one form or fashion. Sometimes they may not even they know that they're using it in some cases, but it really is the fabric and the scaffolding around so much data that normalizes it and makes it useful, and that can permeate within the EMR environment, data warehouses, HIEs, registries. I mean, there's so many different ways in which that you can serve up that data in a way that can be used for analytics and decision making purposes. And so I guess on that last point, how are you partnering, or how are you exploring ways in which IMO can help providers really unlock the usefulness of that data?
Yeah, it's interesting. So I mentioned how foundational we are at the point of care, right, with the data capture, but that data isn't always flowing well into these data warehouses or HIEs for whatever reason. Similar to my sister-in-law's example, things are getting cut off, that granularity is getting cut off. So, I would say this all comes back to that quality as being a foundational initiative, and the disparate data source situation is starting to really perpetuate this data quality problem. And so one of the most common examples that we're seeing, especially with the HIEs, the warehouses, the aggregators, sometimes some of the larger IDNs, is that they're leveraging code-only crosswalks to fill a lot of their data holes versus trying to really get to the root of what the clinical intent is of that record. And understood that that's difficult, but this is where IMO can help, and can help after that data is captured to really try to capture that true intent. So one example that I have is that one of our IMO Precision Normalize customers, this is a large health system, we were normalizing their enterprise data warehouse and saw that there was undercoding. So very generic, high-level coding of a given record, or miscoding, so completely wrong data for over 30% of their entire enterprise data warehouse problem diagnosis and symptom data set. And this is not good for a number of reasons, but I mean, primarily, Dr. Yu, when you were talking about, understanding the patient, comprehensively, we wouldn't be able to have that insight into that data population given that. And that causes, back to the efficiency topic, tons of churn, tons of trying to understand what the real meaning is. And so with that, and obviously the 21st Century Cures Act, with more and more data compounding over time, we see this as continuing to add to the problem. But organizations who are kind of savvy enough to take a step back and really prioritize data quality initiatives are the ones that we're seeing sort of at the high end of these data maturity models, and have a better awareness and have data that's fit for purpose for much of what they're trying to do.
Excellent. Hey, I don't know if anybody has anything to add to Ivana's note there. Otherwise, we're going to move into kind of a prioritization set of topics for each one of the panelists.
So I do want, first off, the story on your sister-in-law. So there is so much in healthcare where we talk about it globally. We talk about these big systems. We talk about AI and ML. But the truth of the matter is that every single individual going through is somebody's someone. Their mother, their father, their child. And we're trying to make healthcare better for each of those individuals. So as we look at the tools, we personalize, the more we do personalize that down to a story, like you told, the more difference we will make, because all the ML and AI in the world isn't going to make the difference. What makes the difference is really trying to understand how to provide that best care for that one human. And then we take that and we make it bigger and bigger. Those stories are rampant. And in a time over this last year, really understanding the stories of the people and the families and the caregivers was critical. So I appreciate you telling that story, and continuing to use passion of our own experiences to make healthcare better. On the data side itself, I would just add that that has changed forever for us. Data has always been important. We are a very large system with a massive amount of data. Sometimes figuring out how to use that is the hardest part. Being able to get ahead of things by having information and applying the analytics and whatever level, we learned a lot throughout it, but to know how to take better care of our patients was organization changing. And I think that you will continue to see more and more deeper dives. We are just now uncovering all the other things that are very interesting and need a better eye as we come out of COVID. So we didn't do as much preventive care. What is the implication of that? So how are we really going to understand? Were we over-testing? Are we going to see increases in cancer cases? I mean, you can go on both ends of that. And there's a lot of really critical data that this one-time pandemic has given us that we have not had in generations. And I think that you're going to see all of healthcare wanting to understand that at a very deep level.
Mhm.
In addition to that, I think we were talking a lot about data, but there's going to be a lot of data. So I think, Dr. Yu, just figuring out how to use AI to filter and better manage that information, what it is that we put in front of our providers is going to be a key part of this. It's also going to be a key part of EMR, and especially what we're working on at Meditech, is to take a look at the patient's problems and pull out of the EMR the data pertinent to those patient problems. So whether it be genomic data, whether it be remote patient monitored data, and basically instead of having the providers actually have to sift through reams and reams of information in the EHR, present the patient information that's relevant to them. And so not categorizing or generalizing a patient record like we're doing right now. It's going that next step. What are your problems? And what data in that record, whether it be normalized and standardized data as well as notes. So we're using a lot of tools for that through a variety of different type of providers to do that. It's a different kind of AI. It is a little bit more preemptive in doing it, but AI can do it as well. So how do we kind of comb through that record to kind of do what Tabitha said, which is personalize the information about that patient to that clinician so they don't have to go hunting for it. So that is a major effort, and we finally have the tools to do that and make that real. So that's going to be a heavy emphasis. And so the good thing about getting data is there's a lot of it, and it's good. The bad thing about getting a lot of data is there's a lot of data. So we have to sort of deal with both sides of this particular equation, and then again making it personal to the patient in front of us and making sure that we have that information so nothing is overlooked.
Hoda, it is such a good point. I'm so glad you mentioned it, because certainly I'm sure we all understand we can't, you get alarm fatigue. If somebody sends you an Excel spreadsheet that says, here are your care gaps. I mean, as a PCP, I look at it and I'm like, wonderful, I guess I'll pass this on, but I really need to know it, Hoda, to your point, when I have that patient in front of me and I can take some action on it. So you're right, it's about not only understanding which of the months and months of records are most relevant, but also just in time when I need it, because I could see it right now, but I really would benefit from the data when I am, in the clinic with a patient, and I can say, aha, we missed a blood pressure check for you. Let's make sure we close that gap for you. Or I need a follow-up on this part of your breast cancer care. We're actually doing this with medical necessity for providers, is just one example. So we all know that every insurance company has different medical necessity criteria, different documentation. That's why we have a fleet of coders behind me that will leave notes in the chart and says, like, please, can you change this part of your documentation? We have armies of people doing that. What we've done, one huge project at Olive that grew out of our prior auth technology is actually being able to surface the exact medical necessity criteria that's specific to that patient's plan. And so imagine as like a surgeon or a physician, you're charting and you do need to order an MRI, or you do need to, refer this person for a surgery. It's so helpful to know exactly the medical necessity criteria the payer is going to be looking for, so you can make sure you document everything that you need to, Instead, what happens is that, we as physicians can't remember all of these 10,000 plans. And so we just kind of make a generic document, and then downstream, it's my coder, it's my prior auth team, it's my course scheduler who tries to figure it out and then fill in the gaps and negotiate with the payer. If we can address it right at the moment where it's most important, we can have a huge impact. So I love that application. It's exactly the way we're thinking about it too, just in time, but just relevant information right when you need it.
Mm-hmm. Yeah, we're certainly touching on a lot of big themes here. The personalization and the personal nature of healthcare and this concept of consumerism, because it's not only the provider that needs to sort down, it is still a lot of information, but then that needs to be translated into the patient so that they're owning their responsibility in all of this, and it's sometimes at the worst point in their lives. They're dealing with a really serious medical condition, and things need to be simplified and distilled for them as well, so that they can engage with their care team and other things to kind of play their own role. Michael, I don't know if there's a question, otherwise.
Yeah, maybe just a few minutes. There's a curiosity from the audience around, you talk about the data and then the move towards personalized care. If you take it further from a business perspective, how does that impact reimbursement, and how do you think about personalized care when sometimes some of these activities might fall into kind of a cost saving bucket or an efficiency bucket? Any point of view on that?
I think you're doing, that's right up your alley.
I was going to say that it's definitely difficult, but I will say that there are, my example with, say, prior authorizations, it's something that every patient hates. Like you just spoke to your doctor or your oncologist, and they say, all right, I recommend this, I need you to have this test, or I need to have this diagnostic test for you. But first, we have to make sure your insurance company will pay for it. All of that is so, first of all, it's an awful a consumer experience, but it's also really specific to that patient and exactly what their medical condition is, exactly what their medical record showed, what their course of care is. And so, we don't view solving prior auth as a one size fits all. The reason why, part of all of the AI that we had to build connects with over 40,000 health plans is because to solve that problem wasn't just saying, hey, let's give you a template and we'll just do the same thing for everyone. It doesn't work like that. We actually match, because we have connection with the 40,000 payers, we pull the specific plan that's relevant for the patient. And then we connect with a medical record and screen 18 months of clinical data. And when we screen 18 months of clinical data, we're looking for the relevant pieces, the keywords, the phrases, the parts of imaging, the pathology results that all can say, aha, here is the bundle that matches this patient's journey. And here is the justification for this person meeting medical necessity. And today, it's all done by support staff in a clinic who tries to make sense of this. And it's very labor intensive. What we've done all the way is we've done that to support providers for all of their payers. But with some of our payer partners, they've even said, we trust your AI for clinical reviews so much that we will enable you to do an automated approval at the point of care. And so the end result, and this is what I find so exciting about it, is I want that patient and doctor to have the counseling in the room, to be able to talk about their care in that personalized way, one-on-one, and then be able to say, and your insurance has automatically approved it. And it's different from gold carding, which is just saying, your previous track record was great, I'll just trust you. This is actually saying we're going to do an AI clinical review in real time, and you walk out the door, you can schedule that MRI, or you can schedule that PET scan or surgery right away, because instead of having a nurse manually review everything, and that takes 5-10 days in the backlog, we can actually use technology to deliver it right then and there. So I think about that as that kind of really using data for that one person, that one patient, because that decision, it's basically condensing everything that we've created our entire health system around, condensed in one moment to allow that patient to walk out the door with the confidence in their care. So just an example, and I think there's different examples all over, but that one came to mind really quickly.
And in a way, Yiding, it's kind of a microcosm of the application of clinical guidelines in an automated fashion. I mean, if we were to take that and blow it out for a provider, Tabitha, I know that the concept of value-based care versus fee-for-service is kind of a trend and a theme that we've constantly talked about, I think, the last 10 years or longer. But how have you seen that aspect of your organization as it relates to shifting to a value-based reimbursement environment and paradigm moving forward?
Yeah, so first off, I would just say, just to the more global question that was asked and the great example that was given, the reality is healthcare finance in the US is difficult. I mean, it's a reality we face. We have to use technologies to continue to simplify that so we can spend more of our time on the care and less of our time on all of these administrative processes that burden the healthcare system. Now, can't snap your fingers and make that happen, but we are on a journey and we continue to see that exponentially growing as technology has improved. To your more direct question on value-based care, so we are a mixed model within our organization. We are in states that are very, very little value-based care and a lot of fee-for-service, to states that are very heavily adopting those new models. As an organization, we are committed to moving down the path of value-based care. We have some parts of our organization that are up to 70% today. And we see the value of being able to take care of the patient holistically. So even in our more for fee-for-service, or sometimes I call it widget-based care model, we are trying to apply those principles of doing what's right for the patient to across the board. So for example, our quality program, we don't have a quality program that says, hey, let's just look at our managed care or value base. Our quality program says, we look at all of our patients and we apply that paradigm across. We want to be the best, we want to take care of them, and we want to take care of them early on. The other thing is we provide care in a lot of underserved communities, and that is our commitment. We are committed to the poor and vulnerable. We are going to provide care, even if we're not paid for that care in many, many cases. To do so holistically, it does mean changing the payment models. So we are looking at our own, where can we do that within our own organization? Where can we partner with our payers? Where can we partner with communities to look at the models that exist, as well as maybe models that don't exist today? Think of behavioral health. We have a huge commitment within our organization to behavioral health. No one has figured out a model that both has access and payment that match. They just don't. But that is not going to stop us. We are going to continue to find ways to invest in that, because we believe not only does it change and take care of the patient, but that changes the community. So practically speaking, we are continuing to increase the number of value-based plans we are involved in, but we are also looking at how do we do what's best in those communities and come up with new models if we need to.
That's fantastic. And I think we have time for one more quick question, and I wanted to direct it to Ivana, but the entire panel, I think, could weigh in here. The concept is around clinical data as the source of truth, but our focus today has been so much around the provider and their operations, but how is that source of truth going to proliferate and provide usefulness and utility across payers, employers, life science organizations? And I know Ivana, IMO is starting to consider what the leverage of that data could mean far beyond the provider environment, but would love to hear from you and Yiding. I know you guys serve payers as well, and see if there's any perspectives there that we could use to wrap up the discussion here today.
Yeah, I would say that I'm starting to see the trend, and we talked about it already, but the democratization of patient data, right? I mean, this is the natural evolution of where things are going. And, I think if we can solve some of these efficiency issues, then providers and patients can become partners in their care plans, right? And yeah, I mean, patients are asking for this already. I mentioned my sister-in-law. I mean, this was her own advocacy, right? I mean, she wanted access to that so that she could help understand how to best take care of herself. But yeah, with this shift, back to my data quality theme, it continues to proliferate the importance of solving the inconsistencies, making sure we have a comprehensive view, and then talking about how we transform that data so that it's consumable to consumers, which is, not an easy task either. And so, I think this is definitely a theme that's starting to progress pretty rapidly.
Yeah, 100%. If you think, data silos are difficult on a provider side, I mean, payers they get so many. I think I was talking to a large payer and they said they have millions of pages of faxes, because guess what? When you have a request for information, you deny for medical necessity, or you do a prior auth and concurrent review. I mean, providers are just faxing documents, and there's so much valuable clinical insight. It's actually interesting that most payers will say, oh, well, my most actionable data comes from my claims information. I might get some from different quality metrics, but they actually get so much information, clinical information, but in a form that they can't digest. And that's really an untapped potential. And I think payers are starting to see that. The other thing that we're really excited to work with payers on, beyond the transfer of data, what we call solving both sides of the fax machine, is being able to allow payer organizations to better navigate, local markets, better tailor their programs for value-based care. They're realizing that to compete, there's more MA plans, there's all these other, direct care. How is a big organization, if you're one of those big national plans or big state plan, how are you going to compete and meet the consumer needs, who say, this is my doctor and this is my network and this is who I want to go with? And the way that we thought about right, has been very stiff at times, and you need data to be able to make more agile decisions. And so we're really excited to use the same type of kind of clinical AI to support them in saying, wow, I have more insights and I should be more aligned. We were hearing about more of these like payviders, right? Or organizations that are both providers and payers. And the beauty of it in value-based care is you're more aligned. You're not doing administrative tasks just for fun. You're trying to get care. You want to control your costs. And I will say, like, we've taken it even a step further by saying we're going to actually work with organizations to assure claims at the point of delivery. And so we've just launched this new Olive Assures unit and offering. And that means that for providers, because we have analyzed clinical data, and because we're able to have that kind of personalized view for that patient's journey in their care, we can say that once you file the bill, Olive will pay that claim. We will take care of any downstream problems. You don't have to worry about chasing that, making sure everything's done. Well, that's the beauty of taking it to the next level, that we can actually assure that claim right at the point of delivery. So always trying to bring, revenue and bring care and removing the inefficiencies. I think those are the areas where providers and payers can really partner to do more of that and reduce a lot of the uncertainty, I think, in healthcare.
On a high note, one of the things that is in the works right now is delivering those requests for information electronically to the payviders and the payers. So that is an active project that I think will help the situation as well.
We need more of it.
Yep.
Well, that's great. Well, this concludes our panel discussion today. Huge thanks to all of our panelists. Thank you so much for participating. We really appreciate it. Michael, I'll hand it over to you to wrap things up in the minute that remains here.
I'll add my thanks to all the panelists. Great conversation. Really enjoyed the last hour. For those that are listening in, if you'd like to watch a replay of today's session, you can visit our website at triple-tree.com/marketinsightslive. And then just a reminder that we have 2 upcoming sessions, continuing more conversations about today's healthcare industry. In 2 weeks, we move to the topic of 21st century primary care. And again, on behalf of everybody at Triple Tree, thanks for joining today's Market Insights Live, and we'll see you in 2 weeks. Have a good day.